Hello, I'm Charles Wooley at Arkansas Children's. This is Providing Pediatrics, a Better Today, Healthier Tomorrow podcast where we are addressing the unique challenges of pediatric care. Today, I'm joined by Dr. Todd Maxson, Surgeon and Chief at Arkansas Children's. Dr. Maxson and I will be discussing pediatric trauma, the trauma system across the state of Arkansas. All right, let's get to it. Dr. Maxson, thank you so much for doing this with me. This is just so fun.
My pleasure. My pleasure. Always good to be back with you. Thank you.
I really do look forward to having conversations with you, whether it's in the parking lot at the airport
Because you never know.
or in the trauma bay or wherever.
You never know where it's going to go. That's right.
True. I really do appreciate you. You bring a lot to the state of Arkansas. And for me personally, I always look for you because you were that calm in the middle of the storm. And it really is a neat thing.
You know, there's a hero in my life, a guy named Bobby Up. Bobby's a pediatric surgeon down in Shreveport, Louisiana. No, Baton Rouge. I'm so sorry. Baton Rouge. I was a medical student. This is ages ago. I was in the UTMB trauma bay, and all of a sudden these 4 kids come in stabbed. Now, this is 35 years ago, but they come in stabbed. And I'd never seen anybody stabbed before. I was sure if you get stabbed, you're going to die. And it was chaos in there. And all of a sudden, the elevator door opened, and this guy came out in this pressed white coat, and he talked softly, and everybody in the room started talking softly, and he just totally took command of the room. And I thought that's the coolest thing I've ever seen. That's what I want to be someday. And so he's about to retire from down there, and I've told that story at his retirement party, and he's a good guy, good influence for me. So thank you.
Well, you didn't show up with the press jacket, but you had a motorcycle helmet.
I did.
In your hand.
I did.
When you showed up.
I missed the motorcycle helmet. Don't tell them.
You know, I really would love to start this whole conversation out with you telling us about the last time your wife let you ride that motorcycle.
I'm not sure that's an accurate description. She was out of town, and so Amy and the kids we were big tennis fans. Amy and the kids had gone to New York to see the U.S. Open tennis tournament, and I was on call. It was a Friday night late, and I actually was. Amy said the last thing she said was, "Don't forget to feed my cats." And so we'd finished operating late. I get on the bike. I'm going home. I'm going by Woodrow, and it's sort of dark there. And all of a sudden, a car comes over the overpass and swerves into my lane. So I swerve, and he then bails out of that and comes right at me and hits me going about 50 miles an hour. I'm going about 20, and I came off the bike and hit the Jeep. And but all of a sudden, 2 guys showed up and, you know, asked me what I needed. And I said, I need you to call 911. I need you to call the hospital and let them know what's going on, because I'm not coming back. In the words of, this is midnight on a Friday night, holiday weekend. So in the words of Magic Johnson, you know, I ain't gonna be there. He said, so I knew I wasn't gonna get back to the hospital. And I've said it a million times to my brothers and sisters that work in pre-hospital, but I've never felt more relief than when I heard the sirens, because I thought, if those folks can get to me, I got a shot of making it. And fire showed up first, fabulous. EMS showed up later, the paramedics showed up later, and they were just outstanding. And you know, you talk about I talk about voting as if your life depends on it. So I made some decisions that night, you know, really as if when my life did depend on it. You do talk about like the ultimate, do you really trust this system? Do you really trust those people? Do you really trust the data that says do this or do this or do this? And there's no more conviction than saying, this is what I want you to do to try to save my life. So that was kind of how that night started.
So you heard your fire gun on scene. Did they put you on a spine board? Did they try to put you in a C-collar or what?
No, I've never apologized formally to the poor medic that showed up, but Yes, he was so kind. He got my helmet off, cuts my Kevlar off, and gets me rolled over and gets a splint on my arm, gets a splint on my leg, and then he starts to put a C-collar on. And I said, no C-collar. And he said, well, we have to put a, and, he was sort of doing the shtick. And I said, no, you don't have to put a C-collar. I said, I'm not impaired. I don't have a head injury. I know what my injuries are. My neck's not one of them. And what the trauma surgeon is thinking, honestly, in the back of my head, I did not say to him was that, I'm having lots of trouble breathing and I'm going to have to be intubated. I know this. And if you put a collar on me, I don't have a cervical spine injury, and this distracting injury thing is not real. It's not a real thing. You should not trust a patient who's altered because they've got a head injury or they're altered from substance. But otherwise, I could tell you everywhere I was injured, and my neck was not one of them. So there was going to be no benefit of putting a collar on. And the downside is that when you go to intubate me, your chances of getting a successful intubation when in cervical motion restriction are cut dramatically. So the surgeon's thinking, you're going to try to intubate me, you're going to put it in my esophagus, I'm going to have an anoxic brain injury, and then I'm going to have a gastrostomy tube and a tracheostomy tube, and, you're going to go home, tell the kids, don't mess with dad's trach. All that's going through my mind laying on this dark road in the middle of the night. But I said, no C-collar. And he starts to argue, and then he kind of looks at me again. And he goes, "Wait a minute, I know who you are." I said, "Yes, and no C-collars." He goes, "Okay, doc, all right." So that, and if he's listening, I thank you. You've saved my life, and I sincerely apologize.
I do not envy his position.
No, that was terrible. He drew the black bean that night for sure, man.
I don't know for sure. I would have argued as well in his position.
Yeah.
Because I have been on a scene before and argued with the medical director who was standing in front of me in SWAT gear. And I was like, hold on, I don't know who you are, but you're telling me, and he's like, I'm your medical director. I'm like, okay. So that's not a great, so we forego the C-collar. You're already, at that point, you're already feeling some trouble breathing. Well, talk me through that.
Yeah, no, I absolutely was having trouble, and it's anxiety. It's anxiety. I had a bad lumbar injury, a bad pelvic injury, and I think losing blood. They did start. The next bad, poor guy. He starts an IV, and he starts to put this clear stuff up. And I said, no fluid. And I mean, he just, no crystalloid, so our principle that we talk about all the time is that I don't have a brain injury. And so I don't worry as much about maintaining a normal pressure when there's not a CNS injury. We can tolerate permissive hypotension for a pretty significant period of time, and the marker of whether it's gone too far is actually the cerebral perfusion. So if that person in front of you can articulate, they can talk, that they're carrying on a conversation, then they're perfusing vital organs, and they're perfusing it enough to be coherent and to be coherent. Do you have a radial pulse? Do you have a distal pulse? All signs that perfusion is adequate. It's not normal, but it's adequate. And we tolerate that really, really well for a lot longer than you think. And the problem with hanging that crystalloid is myriad. Several bad things are going to happen. One is, hopefully that patient in front of you is forming a clot in the places where they're bleeding. They're forming clot, and that's keeping them from exsanguinating. That's just sort of teleologically, that's what we're supposed to do. So, and if you increase their perfusion pressure, you knock that clot off and they bleed more. That's one thing. Second thing is you dilute the clotting factors that are in their circulatory system with a substance that has really zero therapeutic benefit. The only benefit of it is it raises your perfusion pressure. We've just said perfusion pressure was adequate, so no reason to put that into the system. It has no therapeutic benefit. Dilutes out the coagulation cascade or factors. You bleed more. It makes you cold, and that contributes to coagulopathy. So 3 really bad things from that crystalloid. And what you need sort of euphemistically is a clamp on the vessel that's bleeding. And so assessing bleeding first, I think it really does take priority. And I think we're starting to learn a lot about that. We're starting to say C, A, B, C. So control of active bleeding. And so this patient in front of that medic that night did not have a CNS injury, was not impaired, is mentating, has a broken pelvis. He can tell you he's got a broken pelvis, and he's got 2 long bone injuries. You're going to put somewhere between 25% blood loss into that femur. You're going to put about 10% into that arm, and you're going to put up to 50% into that pelvis. You can bleed to death from that pelvis. So there's lots of things he did really well to try to control bleeding. He put splints on, and we considered a binder. And honestly, I don't remember whether there was a binder on or not. I know there was at some point. I don't know at what point it got put on, but he did the things to control active hemorrhage first. Airway, although not airway was fine. Breathing was not great, but he didn't need to intervene. And then he put the IV in, and he chose after a little bit of discussion not to knock that clot off or cause increased bleeding. And we're super close to a place that can stop bleeding. So all of those things were chosen that night, and they really just, they just lined up and went perfectly.
So I'm going to break all that down.
Yep.
Because I feel like when we hung crystalloids and we started talking about mentation equaling cerebral spinal pressure
or perfusion.
I'm so sorry.
Perfusion, central nervous system perfusion enough. So again, what you want is to perfuse vital organs. If you stop perfusing the brain, bad things happen. You stop perfusing the heart, bad things happen. Stop perfusing the kidneys for a long time, sort of bad things happen, but you can usually overcome it. That's really it.
But if I still have a GCS,
I got a GCS of 15, enough to be a jerk and argue, then I've got enough perfusion pressure that I'm not about to fall off a cliff.
What is that? So I'm going to say that's game changer number 1. Game changer number 1 is we're not going to give a whole bunch of crystalloids, break clots. We're going to watch the pressure, but we, like you said, we can look at some, how did you say it again?
Well, surrogates of end organ perfusion. And the beauty of it is that this is not, you don't have to have a blood pressure cuff. You don't have to be in the ED. You don't have to be in an operating room at a level 1 trauma center. You can do this in the field. Is that person mentating normally or not normally? And do I have reasonable distal perfusion? Do I have pulses distally? And in Arkansas, we have, I'm 2 minutes from a trauma center. There are places that are 20 minutes, an hour and 20 minutes from a trauma center. So it gets a whole lot more difficult. But all it really requires, if you break it down just like this, is constant reassessment. My patient is mentating and has a pulse now. I'm holding off the crystalloid. My patient's mental status has declined a little bit, and I can't really feel that. I'm going to give a little bump. I'm going to give a little bump of what I've got. If that's crystalloid, fine. I'm going to give a little bump to bring that perfusion pressure up until I feel a pulse. Maybe mentation gets a little better, and then I'm going to stop. I'm not going to base that on some arbitrary number, a liter, a half liter, 2 liters. I'm going to do it to what the patient needs. So I need a distal pulse, and I need a little mentation. As soon as that happens, stop.
I love that. And here's why I love it so much, because it is hard to get a blood pressure on a pediatric patient in the back of the neck.
Super hard. And this is why they're my heroes, man, because I can't do squat outside of, all of my monitors and my people around, but those folks are in the back bouncing around in an ambulance trying to feel a pulse that's going 150 times a minute, super tough. But
Right. At what point, so if we're getting ahead of ourselves because we're talking about blood pressure before Stop the Bleed, but at what point do we look at pressors? Or is there a point where we start talking about pressors?
So I think there is, and I will tell you that statement I probably would not have made 10, 20 years ago. I probably wouldn't have. It would have been kind of heretical in my circle. But I think that when you need to maintain a certain level of perfusion and you don't want to overload the patient with crystalloid, and you're not going to be somewhere where you can get something else, either a clamp on a vessel or blood products or whole blood, it's reasonable. I think when you're trying to maintain a perfusion pressure specifically to the CNS, the brain and the spinal cord, and you've kind of given the things you've got and you're still low, that's not a bad time to do that. There's a cost. There is a cost in that pressors typically act by squeezing harder on your heart or squeezing down on your vessels so that you increase resistance. So you're gonna pay a price somewhere. Oftentimes your bowel, your kidneys, your liver, you're gonna pay a price somewhere. But in the short term, if you're doing it very goal directed, like you know in your question that you ask, I think that has a place.
Does that look like an infusion or does that look like a spritzer?
I think it looks a little bit more like a spritzer. I think the spritzer is almost the equivalent to that little bit of crystalloid that we talked about to get you over the hump. But I guess if I had to be in the back of the truck, God help the person that's in there with me. But if I had to, I'd give that little bit of crystalloid, and if I didn't have a response, I'd give a little bit more crystalloid, and if I didn't have a response, I might give a little spritzer. And particularly if I'm racing to a place that actually can help me.
So, becoming, like I said, I wish we would have started with game changer number 1, Stop the Bleed. I think that all the things that we're talking about, am I wrong that this is all kind of new-ish?
We've learned, I feel like we make fits and starts in trauma surgery, and unfortunately, we make them around conflict. And so our experiences from the Iraq and Afghan war taught us a lot. And I'm so grateful to John Holcomb, Marty Schreiber, Spinella, those folks that did such a brilliant job at actually recording what they did, and they treated it almost like a laboratory. Not that they withheld anything from our brave servicemen and women, but they were scientific about it, and they taught us that they validated what Ken Maddox had told us 20 years before, that it was okay to let people have permissive hypotension, that damage control resuscitation and damage control surgery are appropriate and work. They validated all those things. They validated use of thromboelastometry to measure a patient's specific biologic need for products. They taught us about whole blood as a better alternative than products. So we got so much out of their experience, and I mean, we all owe them a great debt for that.
It's amazing to me. So, just looking at, we taught so much Stop the Bleed starting back in 2013. And at first I was like, this is so elementary, right? But the more I think about it, the more I see how it's not just about tourniquets. It's not just about applying pressure. Sometimes these patients need bleeding stopped on a surgical level, right? And I know that's just a gee whiz thing to say.
No, absolutely. So here's how I think of that. When my mother was a nurse 60 years ago, only medical professionals did CPR. You had an arrest, and you didn't get it. That was not a layperson skill, right? And the mortality rate from an out-of-hospital arrest was astronomical. We translated that to be a layperson skill. We taught CPR to everybody, and mortality from out-of-hospital arrest plummeted. We're now deploying defibrillators everywhere, and we're teaching lay people to use defibrillators, and out-of-hospital mortality is plummeting. Stop the Bleed is exactly the same thing. You are teaching the lay people, you're translating that from a professional-only skill to a skill that everybody should have, and we will see. They proved it in Afghanistan and Iraq by teaching young medics and every young soldier to do it, and we'll see it happen in the United States. But we got to keep the pressure on there. Absolutely.
No pun intended.
Yeah.
No,
all puns are intended.
So whenever you were talking through your case, that is what you said. You talked about that binder even being that's a form of pressure. That's a form of finding a way to control that bleeding, of finding a way to slow it down.
That and the traction on a long bone. So look for external bleeding. Control that first. Direct pressure, packing, extremities, tourniquets, and then the other things that you can do: the pelvic binder, the traction, and you stop most of it. Most bleeding that controls or stops. Yeah.
And I think the next obvious game changer when we talk through your case is location. Like, am I taking the patient to the right place the first time?
Absolutely. Being designated as a trauma center has a demonstrable effect on morbidity and mortality from trauma. A designated hospital versus a non-designated hospital outcomes are statistically significantly different. Being designated at the highest level possible, a level 1 designation has a better outcome than a level 2. Now, that's not a very popular thing to say, but it's true. It's true, and it's as much striving for that gets you there. Being designated by the American College of Surgeons has better outcome than state designations. And so having facilities in your community or in your region that have made that commitment to meet those highest standards affects outcome. So no choice for me. I want to be in the facility that's prepared for that. And we've talked about this before, but we've got outstanding level 3 trauma centers in the state of Arkansas. But the difference between a level 1 and a level 3 is not necessarily the skill of any one person or the equipment that's available, but the level 3 is out of the hospital, and no matter how fast you're going, to ring the bell and muster the team and have a patient prepared to be in an operating room stopping bleeding, or in an IR suite stopping bleeding, is 20, 30, 40 minutes. There's just no way around that. So I am 2 minutes outside of a level 3 center with somebody that the only thing they need is to stop active hemorrhage. And I've got a place 20 minutes down the road that has a team in-house ready to go. That patient is going to have a clamp on their vessel faster if you drive by that level 3 and go to the level 1 or 2 that has an in-house OR. Now, that level 3 is outstanding and going to do a great job at 98% of the things that you're 2 minutes away with. But the active hemorrhage, you got to take that into consideration. So time of day matters, traffic matters, but all in all, here at Arkansas Children's, we can be from ambulance dock into an operating room in about 5 to 10 minutes, and we're stopping bleeding about another 10 minutes later. So 20 minutes from injury that is life-threatening and causing active hemorrhage, about 15 or 20 minutes until we're doing that. Add on another 30 or 40 to just bring the team in, and it's just too late.
I made this mistake early on, not with a hemorrhage. I was a young paramedic, and I cared for an adult with a big traumatic brain injury. Fell out of some rafters, was posturing on scene, and I started 2 large bore IVs and gave him a lot.
That's what we did, man.
And yeah,
That's what we did then.
I took him to a facility that did not have a neurosurgeon. And I watched a helicopter land and take off with my patient an hour or 2 later. And it still haunts me to this day, knowing that if I'd have just kept the hammer down, diesel ballless in the back of an ambulance, and just kept going further down the road, I could have got into a more definitive care. Patient could have went straight in and relieved that pressure that was building inside of his.
Yeah, that's true. I mean, our joke. What's the most valuable fluid you can give a patient? It's diesel, right? I mean,
it's all about time, It's really all about time. And going back to your case, man, you weren't lucky, but you were in the shadow of a level 1 trauma facility.
And for me, it's even more pertinent because I had the privilege of training there. I had the privilege of training most of the people that were there, and I know what they deliver. I know what the care they deliver, and I know they took great care of Todd Maxson that night. But I also have seen him take great care of people that they've never met before, and I had an interventional radiologist in the suite in about 20 minutes on a holiday Friday night at 1 a.m. I had an operating room set up and ready to go. I had a massive transfusion available to me. So all the things that make a difference were available because that is the standard at an American College of Surgeons Level 1 center.
How much of a role, and I know the answer to this, but I want you to brag on yourself a little bit. How much of a role does that trauma system that you helped put in place set that up for patients all across the state to get them to that level 1 facility, to get that, if it's an appropriate transport to a level 3, what does that look like and how did that play in?
I think for me, honestly, it was less important because the UAMS was the closest facility. I think even pre-system, an excellent medic would have recognized the acuity of this and gone to the closest facility. And I think the differences is that I would not have had the absolute confidence that all these things were going to be in place once in the trauma center because they weren't required. When you haven't held yourself to that standard, it's not required. And you may have most of it, but you may not have all of it. So I might not have had an interventional radiologist available within 20 minutes to embolize my pelvis. Where I think this system has been a game changer, is the theme of our talk today, is when this injury occurs in rural Arkansas. And I think the things that Arkansans benefit from based on the system are they get real-time support. Both the medics and that first hospital get real-time support from so many different places. ATCC is a game changer. To be able to call and know what's going on, you're equidistant from 2 hospitals, and ATCC just sent a big case to this hospital. I want you to turn left. That is situational awareness that you can't possibly have in the back of the truck otherwise. You can get real-time medical control help. You can get to that hospital and get on with a higher level trauma center immediately through ATCC. This didn't happen in 2012. It just didn't happen. And then that hospital would start, first of all, they didn't have a system set up to care for this. So it was, unfortunately, one great ER nurse and one great, usually locums EM doc, and maybe one surgeon kind of battling this thing all of themselves because there's not a system put around them. And then they would get on the phone once they'd done their best and try to get you out of there, and they'd get the runaround. We need I know he's bleeding to death, but he's also got to fracture his toe. Let's call the orthopedist first and see if they're okay accepting him. And our acceptance time was 6.5 hours. And so ATCC is a game changer. And folks come to us from all over the country. I was on the phone call yesterday with the state of Kansas. Right after this, I'm going to be on the phone call with the state of Ohio. And what they want to know is about how that piece works and how that part of the system works. So Arkansas got it right. They got it right, and it's been huge. And interestingly, if you said who would be the biggest opponents if the trauma system were to be threatened and go away, it would be the small hospitals in our state. Every small hospital in our state would scream, you can't take that away from us because it saves lives and it saves us.
Well, I mean, just the case that I shared with you from my experience, I would have got in my truck, called report, and they would have said, no, you need to go to the next available. And they would have said, you can go past this hospital because this is the next hospital that's going to be available for neurosurgery for your patient. And it would have saved his life. That's just, wow, what a game changer. Really is awesome.
It's going to work for all time-sensitive diagnosis. I heard a wonderful talk last night about maternal mortality in our state, and the same time-sensitive processes for that, for stroke, for STEMI, are for pediatric sepsis. They're all the structure necessary is all the same.
Love it. What a game changer. That's so cool. Tell me a little, I know you have those statistics in your mind. When we started the trauma system, what did morbidity, mortality look like for pediatric trauma versus now?
So 3 different groups came and evaluated the state of Arkansas for different reasons. The CDC came, the College of Surgeons came, and ACEP, the College of Emergency Physicians, came and did evaluations of our state for different reasons and found us to be the worst prepared in the country. Usually we rely on Mississippi, right? But
oh no,
not this time. We couldn't stay off the bottom on this one. We were the worst prepared in the country for time-sensitive disease. If you were a child prior to 2010 involved in a car crash, your chances of dying were 3 times the national average. 3 times. And so we just had so much opportunity there, much of which we've done a great job taking advantage of. The system helped us. And now it's really time to take another step for us, though, in pediatric care. It's really time for us to pay attention to the Peds Ready initiative and make sure that there's training and equipment available everywhere, in every rig, in every hospital in the state, and we'll see another huge decline in pediatric morbidity and mortality if we follow very, very simple principles there.
I love that, and it's something that I care a lot about. I've spent a lot of my time trying to increase readiness for pediatric care in the back of ambulances and across the state in emergency departments. And I've done simulations where we go into very well-known adult hospitals, ERs, and do a pediatric simulation. And the list that is met, I would ask somebody, a charge nurse or somebody, say, write a list of all the supplies, just the supplies and equipment that you are lacking at the end of this simulation. And the list is long every time. It's just not something that's on the radar of even pre-hospital providers. And if you're taking care of strictly adults and every once in a while a kid wanders into your emergency department, you don't think about looking. And here's a lot of it. If I open that pediatric bag, I have jinxed myself. There's a jinx around it.
But it's got to be the worst feeling in the whole world to the principles of the care are not much different, right? And to know I need to act. I need an airway. I need to decompress a chest. I need IV access. I need to immobilize something. I need to do it, but I don't have the equipment and I haven't had the recency of training to do it. That's got to be a terrible feeling for an otherwise excellent, well-trained medic, EMT, ED nurse. It's got to be it's a horrible feeling. I remember being a kid and we were out one night riding around with our buddies, doing things that I don't want my kids doing today. And a guy crashed his motorcycle right in front of us and had a head injury, and he was obstructing his airway. And I know that now. I didn't know what it was then. He was just making this horrible sound, and he died of an anoxic and traumatic brain injury. And I just thought, I just sat there watching because I had no idea what to do. And it's got to feel exactly like that when that PEDS patient comes in your hospital. And so for everybody, I just think we can do so much better by doing this training, investing in the equipment, investing in the training to use the equipment properly, and having a champion in your hospital that liaisons with Arkansas Children's. So just fabulous opportunities.
Absolutely. And the EMSC here at Arkansas, the state of Arkansas, the EMSC division of the health department, they have all of the checklists that you could need for PEDS Ready. There's so many resources around that. I share a very similar experience. Had a really bad car wreck, and the person that was riding with me in the passenger seat was pinned and was in and out of consciousness, and I did not know what to do. And that was that moment where I was, what's going on right here? But man, that feeling. And so you're absolutely right. I remember being on the ambulance and going, am I prepared to take care of a sick kid? Felt very confident. If it was you on your motorcycle, I would have put a seat collar on you. But but a kid is a whole different thing. And PEDS Ready. I'm glad you brought that up, because that is really
that will be a game changer. That is a game changer, and we will be proud of ourselves as a state when we see our pediatric mortality plummet because we invested in that.
I would love to help. So another thing that you alluded to, and I feel like is definitely on that list of game changers, tension physiology.
Well, so it helps so much if you can sort of conceptualize it. I've got some mass in my head, my chest, my abdomen that is not allowing perfusion. So I've ruptured my cerebral aneurysm. I have a big epidural. I have something that's taking up space in a fixed compartment, and the pressure's building to a point where I'm not perfusing anymore. The blood flow's not going. Same thing in my chest. I've got air or blood in my chest, and it's shifted my mediastinum so that my return to the heart is poor through my vena cava, and I'm not generating cardiac output. I've got it in my abdomen. I've bled in my abdomen. I've got swelling from too much damn crystalloid, but too much crystalloid, and I've decreased the perfusion pressure to my bowel and to my kidneys, and it's all the same. And relieving that pressure changes everything. And the nice thing is that relieving the pressure in the brain takes a neurosurgeon. Relieving the pressure in the abdomen takes a trauma surgeon. Relieving the pressure in the chest takes a knife and a finger or a big angio catheter. And the confidence to say, I know how to do it, I know when to do it, and I know that there actually is nothing bad that can happen from doing it. And if you've got those three things, then you're going to save a bunch of lives. Do I ever needle somebody that didn't need a needle? Absolutely. And don't think twice about it, because I got a patient in front of me. Again, it's easy for me to be a Monday morning quarterback, but you're in the back of that truck. You're sitting on that street on Markham, and that person in front of you is hypotensive. You don't see external bleeding. You don't see a long bone fracture. You can't do anything about the belly or the head. The pelvis is stable, and this patient's hypotensive, and you don't hear good breath sounds. And there is zero downside to using that decompression as a diagnostic and therapeutic technique. And so needling that chest, and the game changers for me have been how we do that. We, for decades, second intercostal space, mid-clavicular line. Well, I have gained a little weight since I was in high school. And, that angiocath might not reach my pleural cavity in the second intercostal space anymore. But I can go over now, I know to go over to that fifth intercostal space laterally where I would put a chest tube in. And that's thin in everybody. It's thin enough to feel the rib, get a needle in it. Maybe even better is a knife and a finger thoracostomy, because that's going to relieve both air and blood. If I've got it, I'm going to relieve that tension physiology. It allows my patient to get some venous return back to the heart, generate some cardiac output, and it's going to buy me a few minutes.
I love how you related that to other parts of the body, not just went straight to the chest. I mean, we could do compartments.
Exactly. I break my tibia, and I've got so much swelling that I lose perfusion to my leg. I've got to open the compartment. I can't do that on the field, but I can decompress that chest.
I love it. Do you think there will be a day that we'll be able to do a knife and a finger thoracotomy in the field? I feel like it's coming.
Yes, absolutely. I think there are places today. That under medical control, under a protocol, that finger thoracostomies are absolutely acceptable. And I just think they've got a benefit, especially in the unconscious patients. Tough to do, somebody who's awake and alert, but the unconscious hypotensive patient, I think it's superior. I think it's superior to a needle thoracostomy.
What do you think? If you're a paramedic and you're in the back of a truck, how much weight do you put on mechanism to pull that trigger to say, okay, the mechanism of injury, this patient was a front seat driver that head on into a tree. I'm thinking all trauma to the chest.
It's huge. It's huge. Rapid understanding that you had a rapid deceleration against something that was immovable makes a lot of difference. And this is why the report is so important. And this is part of our challenge in Arkansas, right? Is local team shows up, they call for support comes in, they pass the patient off, maybe a second support comes in and it's passed 3 times, and then it comes to our hospital and you say, okay, tell me a little bit about the mechanism. And they go, I don't know, we weren't the ones on scene. I think that really hinders us. That really puts us behind. I think that few more seconds by the pre-hospital folks to be disciplined about giving a really good report. And, one thing that's super important in our world is restraint status. Totally different game, totally different set of expectations among our care team if a child is lap belt restrained only. So you would probably hear restrained. I'd say properly restrained. We don't know. I mean, restrained. I just got restrained. A game changer. I was in a car seat. The car seat stayed in. The baby was strapped in 5-point, stayed in the car seat. We extricated in the car seat versus the car seat wasn't, and the car seat became a launch vehicle with the kid in it, or the kid was restrained in a booster seat, 3-point restraint, has a big mark across the shoulder versus a lap belt only. A huge difference in the set of injuries that we're expecting and where we put our priorities first. And so I would put a plea to our pre-hospital brothers and sisters and say that information is critical and worth 15 more seconds.
I agree. And I think that it gets lost in translation. Like you said, I think that's a huge problem. And I can remember cases where I was working in the emergency department and taking care of patients, and it would be hours before I'd get their real story. And then I would look back and go, oh, they totally make sense because their physiology says all of these things. I'm watching all this happen right in front of my eyes. And now that I know the mechanism is they were on a side-by-side and they ran into a tree or they rolled a side. All that really, really matters.
Makes a huge difference. And they see 100 times more adult stuff. And so, you get the horrible picture of the car, but that doesn't tell us what we need to know about the restraint status of the kid. So huge difference for us.
And I see kids every single day these days, and they're not restrained in the front seat. And then I already jumped on the four-wheeler bandwagon. I don't know how I survived, Dr. Maxson. I rode four-wheelers and three-wheelers. But wow, we have an issue that, we need to revisit and remind people that, helmets matter.
They matter. And I love being in rural Arkansas. I hunt, I fish. I use the utility vehicles for those purposes, and I know that we have farmers and ranchers in Arkansas that use them for their business, but that's actually not where we see the mortalities in the peds patients. To be honest, we see it when they take it on a road. It's vehicle versus car. It is that, or it's putting somebody on one of those vehicles that doesn't really even ride a bike yet. Like, I don't know rules of the road. I don't understand the physiology of riding a bike much. And then I get on this thing that weighs 1,500 pounds, and so I know it's part of our culture, and I celebrate our culture, but there are common sense things that we should be doing.
Absolutely. Yeah, that's scary. So I think that we could add report restraint details to that game changer. I think that would definitely help. And how do we fix that if it's lost in translation? If I'm the paramedic and I'm telling the level 3 facility or the first facility that I take the patient to, this is where they were restrained, and by the time they get to us, we really don't know the whole story, because let's just say that they were flown to us, and the flight team got the story from the attending who came in. So there's a lot of hands changed.
We've all got a cell phone in our pocket, though, and Amy has taught me this, that when she tells me to do something, if I'll go to my phone and do a memo or write it down, I have at least a 50-50 chance of accomplishing that. And so, maybe that's the low fidelity answer, is just pop that cell phone out, record the report. And that way I'm now stressed in the back of that truck trying to save a life. I don't have to try to remember details. I'll just play it back for you when I get to the facility.
I know that's a great thing. And then I know a lot of those details are being captured through ATCC, through our call center here at Children's Hospital. A lot of that information is transferring over and is available too. So maybe on our side, we find a way to maybe go back and review those things so we see them a little bit better. So we've nailed down a few game changers along the way. Is there anything that comes to mind that you would say this is something that definitely is a game changer for pediatric?
Well, I think I'll sort of review them again just to be sure I'm covered them. I do think first and foremost the preparation. Well, first and foremost is the common sense injury control measures. Again, I hunt, I fish, I'm off road. I get all those things. There are some common sense things that we could be doing to decrease the burden of injury to children. Second is the preparation for when that fails. Are we prepared? Our system is well prepared. Now, is our hospitals and their personnel well prepared for the child? That's the peds readiness. Those two things are huge. Now, the principles of care, ABC, and control of active hemorrhage through a means of stop the bleed, of pelvic binders, of traction. All those things are important. The decompression of the chest is a simple maneuver that should be promulgated and used more liberally. Access to the highest level of trauma center that's available is the last, I would say. And so those are the things that matter to us. And then I think from a global sense, I think our participation in multi-center trials, so research is important. It's important. It's what drives us the next step. The conflicts move trauma care forward, and they moved even pediatric trauma care forward in this last conflict, but there's still things we can do between those. So the research matters. Participation in multi-center trials across the country and across internationally are important for us, and those are where we'll see the next set of game changers.
So I'll always include in this talk questions from the field. So I reached out to a few friends around the state, said, "Do you guys have questions?" When they heard it was Dr. Maxson, they were like, "Oh."
That one poor medic is probably on there right now. Go, just give me his address. Yeah.
Okay, I'm pretty sure you already have it. So I did have a couple. So Latricia is a flight nurse at Survival Flight and has been around forever and ever, and she's still young and wonderful. Well, something we've already talked about. So pelvic binders. What ages? How do you really feel about them? Talk through, like, what is the application for that? Because I remember you telling me at one point you were like, only for open book pelvis.
Oh, there are different types of pelvic fractures. The most common that we see is the open book, which is a compression anterior to posterior, and it opens up the front of the pelvis and it breaks the ligaments in the back. And it's those broken ligaments in the back that bleed that cause that. In that case, there is a benefit of bringing the pelvis back together and closing down the volume there, and that helps with bleeding. That's tough to figure out in the field. That's tough to figure out in the field, because if your injury is from the side and you just break one side and its ligaments in the back and fold it in, that's a lateral compression, and actually putting a binder on that can make it even worse. The third is a shear, where you sort of you can think about it like falling from a great height on one leg. One side of your pelvis shears against the other, and those aren't really helped by a binder. So I find it tough. I find it tough in the field to figure that out. Let's say your patient goes, though, to a first hospital and they get a pelvic film, and the folks there tell the transporting crew, okay, this patient's got an open book pelvic fracture. Medic would be absolutely right to suggest in that case, well, let's put a binder on for transport. That would be good. I guess I wouldn't fault anybody that said my patient's hypotensive, I was transporting a long distance, and therefore we put a binder on. But just understand that all injuries are not, all pelvic fractures are not the same, and there's a couple that you can actually, you could make worse. So I guess if I was throwing a Hail Mary for somebody that I'm on the Ozarks and I've extricated somebody from climbing at Ponco and I've got a long way to go, and their looks like their pelvis is out, their legs are externally rotated bilateral, they're hypotensive, I'd put a binder on. If I'm sitting on Markham 2 minutes from UAMS, I wouldn't put a binder on.
Right. But ages.
So the kids can have them. The good part is that the smaller the child, the more rat-like they are, cat-like they are. You can squash them,
sure,
and you're not going to break them.
Right.
And so the chance of those pelvic ligaments breaking in the back and cutting those vessels and having life-threatening bleeding from a pelvic fracture in a small child that doesn't just get absolutely run over, but has been in a car wreck, pretty uncommon, almost unheard of. Once we start into the driver age, that 15, 16, 17, that's when we start to see that fracture pattern. So I would tend to go to a binder sooner if I was picking up a 16-year-old from a car crash with a longer distance than I would the 8-year-old in a car crash that was restrained. I think it's really sort of anatomically and physiologically, it's when things have sort of matured.
Okay, I'm just going to take the liberty here. What do you think about traction splints?
So I think traction splints can be lifesavers. First of all, it helps the pain. Having that limb split, it changes the pain completely. So it also, if nearly aligned, slows down bleeding. It can be overdone, and so I would say there ought to be a mantra that's chanted. You feel for a pulse. If there's a pulse, You put a splint on, you feel for a pulse. There's no pulse, redo your splint. Redo your splint. You haven't done a good job until you've got a splint on and the perfusion was the same as before you put the splint on. Now, I don't have I've got a supracollar humerus fracture or a widely displaced femur fracture, and I don't have a pulse to begin with, then no harm, no foul. But you can overdo it. So I would say every time you put a splint on, feel a pulse and say to yourself, did I do any harm with that? And be brave enough to redo it if it's not just right.
Okay, so Ronnie Pafford asked a question about sedation and pain control in that 1 to 6 year old age group. What is kind of the recommendation from that?
I think let's take them separate. I think pain control is an essential. I think you have trouble getting an exam without good pain control, and I think if you're disciplined and use a formula, you've used your Broslow, you've talked to the mom about what the weight is, and you're accurate. 0.05 mics per kilo of fentanyl is unbelievably helpful, and would have a hard time overdoing that if you've gotten the weight right. So be disciplined, use the Broslow, speak to a mom, speak to the kid. Most kids that can talk to you know how much they weigh, but speak to the mom, get a Broslow, 0.05 per kilo of fentanyl, huge difference. And you can do it, and it lasts just a few minutes. So you can do it. I would steer away from the stuff that lasts longer, the Dilaudid, the morphine. You use the fentanyl. It's shorter acting. If you overdo it, it's going to be back in a minute. Sedation. I would be very, very careful with sedation. I would try to avoid sedation unless probably medically directed, because you take away a little bit of tone, and if they're right on the edge of sort of holding their perfusion pressure, you sort of lose it with that. And it's easy to overdo the sedation, and it's easy if you're doing that with pain control to get an additive effect that causes respiratory distress. So I would say yes, always to pain control in the little spritzers like we talked about. I would say be very careful about sedation.
The thing that scares me with sedation is like, how are you going to control that airway if you can't get that ET2?
Yeah.
I think that's the one game changer we may not have discussed, is getting that airway. And there's going to be, most of the time, you're not going to have to get it. You can use a eye gel or something, but if you're going to have to intubate that pediatric patient, making sure that you really are up on that skill, that's a hard skill.
It is. Bagging the patient is a hard skill. And I would go so far as to say that I think that's actually the most crucial skill, because everybody gets bagged. Not everybody has to be intubated, but everybody that is sort of on that cusp of respiratory distress or entering respiratory stress is going to get bagged. And if you're effectively bagging and you're 2 minutes from a hospital, you're doing great. You don't need a piece of plastic. You're bagging. It's the harder skill. So the right equipment, this is, again, PEDS ready, and it's as important for the pre-hospital provider as it is for the hospital. Do I have the right size mask? Do I have the right size oral airway? Do I have the right size tubes, the right size eye gel? And for me, it's the what if. So I can bag, awesome. I can't bag, I'm going to do something definitive next. I'm going to do an eye gel, I'm going to do an intubation, and I need to have had those skills recently. I fly an airplane, I'm a pilot, and there's a big difference between currency and proficiency. I may have done my required mannequin intubation 5 times this year, but if I haven't done it recently, I'm going to be rusty. And so I would say every time you pop in our hospital, come over and let us walk you, go to a mannequin, go get some training, do it. I can't fly in the clouds enough to feel totally proficient. I just can't do it.
No, I understand.
I can be current, but I'm not necessarily proficient or safe. And that's what that's what you want as a good pre-hospital provider. You want to be confident in your proficiency and your safety. So you got to practice it.
That's hard. It's hard to get access to that. It really is. I understand that. So learning how to bag a patient properly, learning how to use a supraglottic airway is a really good fallback. Most of the time that works out for us. Okay. So I asked this question of every one of my guests as well. How long have you been doing it? Before I get into the question?
Man, I finished medical school in 1990. So then a 6-year surgery residency here in Arkansas with a year and a half at Arkansas Children's during my training. And so finished surgery training in 96, pediatric surgery in 98, did trauma after that. And so it's been about 25 years at a level of I'm making the decisions, and it's been in the whole thing for, 30 plus years. Long time.
How do you cope? How do you deal with those hard cases? I know you've had hundreds of them. How do you deal with that? So I love that on this podcast, we have the opportunity to ask people like you, how have you been successful at that?
I'm not sure I always am. I'm not sure all of my coping mechanisms are totally healthy or worth talking about on a podcast. But for me, having children, my own children, made a huge difference, because I think at times, if this were Marianne, Andrew, or Jake, I would want somebody that could close their mind to the emotional part of it and focus on a task. And I think the only way we can do that is by drilling over and over. Now, fortunately or unfortunately, we have enough real life practice, but for me, it's a meditation practice. It is the repetitiveness of doing the skill. It's thinking about that I am mission driven, because that child is my child. That child is some mother and dad's child, and that for me, that pushes me further. I think being in a teaching organization pushes me further too, because I think it's such an incredible honor and responsibility to model behavior in front of trainees. It doesn't mean that I have gone home and cried. I have left the OR, I've left the trauma bay after being in that little room and gone by myself and just broken down and cried. I have a fabulous wife that is in medicine, that gets me and gets what we do. I have incredible support around me. I have used mental health counseling for myself multiple times in my life, particularly around my injury, that made it possible for me to come back and work when I might not have been able to. And so all of those resources, I've availed myself of, and they've helped.
Thank you. Thank you for sharing that, because it really, when you're talking to the group that we really want to hit with this podcast, we really want paramedics, EMTs, physicians that work in ERs around the state. And we're talking to them about taking care of kids. And taking care of kids hurts, especially when the outcome is not great. And it's not always great.
It's not gonna always be great, but it's gonna be greater if we're prepared, if we're doing the things that we know we're supposed to do to prevent it and take great care of them, and you're part of it, and it's not going to always go great, but you're doing your best, and you're doing what you would want done if it was your kids. If you're doing that, you can live with yourself. And if you're having trouble living with yourself, get some help. Absolutely get some help.
Absolutely. There's nothing wrong with that. It's encouraged. So one last question. Tell us what you love about your job.
So my job is morphed, like my favorite day is a day that it's all breaking loose and I just get to go to the trauma bay, get to run to the operating room and get to be a trauma surgeon. That's the greatest. That's the greatest. I say all the time, it's like Christmas, man. It's like opening up a little present for me. And I don't wish anything bad, but I sure am glad we're here. At this point in my life, I feel like a proud grandfather all the time. I watch our team perform, and they're just excellent. They're better now than when I was running it. And it just, there's nothing I could be more proud of. And then my work has morphed a little bit. I'm the surgeon in chief now for the Arkansas Children's System, and I get to sit in the boardroom. I get to sit in the C-suite, and I get to bring our challenges as providers to our executives. And our executives at Arkansas Children's listen and respect that and move us forward because of what we tell them. This organization has just been fabulous to me and for me. I've had lots of opportunities in my life to go lead programs in other places. I intended to come to Arkansas and spend a few years getting a system up and going, and then I was going to do what I'd done a couple times more, move to the next big challenge. This is the beginning of my 15th year here, and we will retire here, die here. These are my family now, my people, and I do it because of the people I get to work with, those medics, the people in this hospital, the executives at this hospital. They are mission driven. They're doing this for the right reason, I'm grateful. I'm just grateful to get to be here. So
that is just absolutely outstanding, and I feel you, and it's wonderful. Thank you so much for spending this time sharing not just your expertise and not just but thank you for sharing your heart.
Yeah, my pleasure. It's easy to do when you do this work. So thanks for the opportunity.
I agree. Thank you so much.